There we go. Okay. So I want to thank everybody for coming. I did give grand rounds last year in the spring where I talked a lot about the cognitive and psychiatric symptom presentation of those with long COVID. I'm going to try not to rehash or get into the weeds with those issues. Instead, I think, the pandemic has offered us an opportunity to really see in real time the process of scientific exploration as it comes to biological as well as psychological and social contributors to an illness experience. It's really brought to fore the importance of scientific communication and expectation setting. And it's brought to light underlying sort of biases and sensitivities with respect to the nature of illness experiences. There's always been patient groups who have advocated for their care and to be taken seriously by the medical community. COVID has really brought this to light in a way that in some senses has made it tense for researchers and providers to sort of follow the science as it relates to psychological contributors to somatic symptoms. On the other hand, it's also given us an opportunity to have a larger conversation about the ways in which mental health impacts our experience of illness and vice versa. And so that's really what I'm going to focus on today, with a focus on the psychological and sort of social, and less focus on sort of any studies of the underlying biological mechanism. So the diagnosis of long COVID is something that's not entirely clear. It varies. Long COVID itself is a patient-derived term, really just reflecting any symptom that is persisting post-COVID. In February of 21, the NIH coined the term PASC, or post-acute sequela of COVID-19, to refer to the direct and indirect consequences of the SARS-CoV-2 infection on human health. And for that, the symptoms have to be present for at least 4 weeks. Then in October of 21, the World Health Organization made their definition of post-COVID conditions, which requires symptoms for at least 2 months after an acute illness. And these are really sort of non-specific symptoms. You don't necessarily, like our patient, have to have had a positive test, so it's not clear that you ever actually had COVID, although 98% of adults in the US do have antibodies, and so most of us have had COVID. But the symptoms can come and go, and they're very non-specific, which makes it difficult to study. There have, however, been some attempts to define what PASC is, and so this is a nice study that just came out of the Recover Initiative, which is a longitudinal NIH prospective cohort of infected and non-infected individuals. And what they were doing is looking at about 10,000 participants who reported persistent symptoms at least 6 months after their infection, and comparing them to those who did not have a COVID infection. They took a big group of symptoms, whittled it down to those that were present in 2.5% of the sample, and for which there was an odds ratio of at least 1.5, differentiating those with and without a confirmed infection. And then there was a weighting procedure, and essentially they came up with this scale of 12 symptoms. They each have a weight. You sum them up, and they found that the optimal cutoff for identifying PASC positivity was a score of 12 or more. Right? So obviously you can get there in a number of different ways. You could have loss of smell and taste, and brain fog, and chronic cough, and you would be there, but you could also have a range of just sort of lower weighted symptoms. And that variability speaks to the point that phenotypic variation is really sort of the rule in long COVID. They went on to look at symptom clusters, 2 of which have really prominent sort of brain fog components, along with post-exertional malaise and fatigue. And this phenotyping is really important because right now the field is awash in different findings with respect to risk factors and potential mechanistic pathways, and that muddles our ability to provide effective care. We want to be targeting our interventions to the symptoms and presentation of particular patient groups, and it's very clear that this is a variable condition. So this is one set of findings with respect to symptom clusters, but they're certainly not the only one. This recent paper out of Cell found 8 patient groups. This is work out of Ben Abramoff's group up at Penn. It was published just a few weeks ago. 3 out of these 5 groups do have prominent cognitive symptoms associated with them. And they're also using factors like illness severity and need for hospitalization rather than just patient symptoms to help define their groups and look at phenotypes. And I said I didn't want to go into much of the sort of biological mechanistic pathways, but I do want to touch on this study simply because patients are already asking about it, as well as some colleagues. What they were looking at here and what they found is that peripheral or circulating serotonin was reduced in those with long COVID, and that depletion appeared to be driven by viral RNA-induced interferons, which were diminishing tryptophan uptake, leading to hypercoagulability and increased MAO expression. And in a related mouse model published in this paper, that diminished serotonin was impairing cognition via disruption of vagus nerve signaling. So really interesting work is being done. Our groups are looking at things like cortisol levels and blood-brain barrier permeability, as well as risk factors, particularly in older adults who might be at risk for having a progressive cognitive decline post-COVID. So I bring that up to say that I'm not sort of in a camp where I don't think that there are important biological mechanisms that we need to be looking at, and certainly it's a false dichotomy, but that's not going to be the talk of this round. So we know that the incidence and prevalence are changing over time, and that's really due to 3 factors. We're seeing less long COVID because of vaccination. Most studies show that getting vaccines, it reduces your likelihood of having COVID, of having a severe COVID illness, and that's associated with reductions in long COVID rates. The antiviral Paxlovid is also associated with about a 25% reduced rate of having long COVID or developing long COVID. And then as we've moved through the pandemic, the more recent variants seem to be associated with reduced risk of long COVID. So Delta, it was around 10 or 11% of patients. Now with Omicron, it's about 4.5%. These are data from the 2022 National Health Interview Survey, looking at the prevalence of long COVID. These are individuals in the community who said, yes, I've had COVID, or been told, I had a positive test, or a doctor told me I had it. I had new onset of symptoms. I was symptomatic when I was acutely ill, and those symptoms stuck around for at least 2 months. And so what we see is that about 7% of the US population, population has ever had long COVID, with about 3.5% having any history of long COVID. We do see, as we appreciate we see very regularly in the literature that women are more likely to report long COVID than are men. It's also the case that we tend to see higher rates of long COVID in younger adults, so people in middle age, sort of that 35 to 50 age span. And the prevalence rates are higher in those in rural communities relative to more urban environments, which may have something to do with access to care as well as vaccine uptake and things of that nature. So in addition to female gender and age, there have been a number of other factors that have been shown to be risk factors. It certainly matters how you ask, who you ask, and how you're measuring that. But generally speaking, I think these 2 studies sort of represent reasonably well what's being found. So being younger, being female, being members of underrepresented minority racial and ethnic groups, having lower socioeconomic resources, smoking status, and then a number of different medical and psychiatric comorbidities, including pain conditions and anxiety and depression. The study on the right from the RECOVER trial also notes that hospitalization is a risk factor for long COVID. Patients who are more acutely ill end up getting hospitalized, they go into the ICU, they're more likely to have long COVID. And there was a real concern that there may be something specific to COVID that might be putting those ICU patients at risk for really poor outcomes. But the data have shown that as time goes on, that people who are in the ICU for long COVID, or for COVID rather, versus those in the ICU for other reasons, they tend to fare equivalently, which is there are elevated rates of cognitive dysfunction and psychiatric symptoms and distress. But there doesn't seem to be something specific about the COVID experience that's driving that. It really is the ICU experience in general. And long COVID has functional consequences, like we saw with our patient. Those with long COVID are often working age. They're less likely to be working at all and less likely to be working full time. It's also the case that as of July 21, long COVID is a condition that qualifies you for disability under the Americans with Disabilities Act. So we're often being asked to weigh in on whether someone has a cognitive disorder, for example, that precludes their ability to work, or whether they need accommodations in the workplace or in their school environment. I like this figure from my collaborator, Catherine Winman at University of Bonn. She helped establish the German guidelines for rehab of long COVID. And it's really highlighting factors that exist across several levels, from sort of society and environment to person-level variables and illness variables that work in both bottom-up and top-down fashion to affect someone's experience of their illness. And I'm going to walk through a few of these. And I want to start by just, acknowledging sort of the social contributors to long COVID. We appreciate that particularly in that first year of the pandemic, there were really elevated rates of anxiety and depression worldwide. The predictors tended to be being younger, being female, having more pre-existing health conditions. Those probably sound familiar because they're also some of the risk factors for long COVID that we just talked about. And a paper that came out in JAMA last year using data from the Nurses' Health Study showed that depression and anxiety measured very early in the pandemic, before anybody had a COVID illness, was associated with an increased risk of persistent symptoms following a SARS-CoV-2 infection. We see this very nice sort of dose-response relationship. Early psychiatric symptoms were actually a stronger predictor of persistent symptoms than other established risk factors like asthma and high blood pressure and things of that nature. Additionally, people who had 2 forms of emotional distress were about 50% more likely or at increased risk of developing long COVID if they had a COVID illness. This was recently replicated in molecular psychiatry in a prospective study of anxiety and depression that was measured, again, early in the pandemic in about 25,000 individuals in a cohort study that had been sort of going on pre-pandemic. And what they found is that those who were in the highest psychiatric symptom quartile were more likely to have persistent symptoms, again, in this dose-response relationship. Early depression symptoms were the strongest predictor of long COVID development, both for the people who ended up going on to have a COVID illness, as well as for those who never had a COVID illness. So the long COVID symptoms are really non-specific and associated with psychiatric vulnerabilities. And against that backdrop, we're seeing a lot of, in some ways, concerning news reports about the types of symptoms and the severity of symptoms that patients might expect. The early days of the pandemic were very unquestionably a time of sort of uncertainty and fear. And as the pandemic moved along, there were messages like the one above that suggest that patients might be really at risk for very severe cognitive symptoms that don't really comport with what we see as neuropsychologists in the long COVID space. They highlight this woman who was infected in October of 2020. She was young. She had pretty mild illness. She was not hospitalized. But she took a cognitive screener and scored 25 out of 30 and was told that she has pre-dementia, which is not, it's an unfortunate term that really implies that major cognitive difficulties are on the horizon. And you see here in the caption that she's got sort of a index card of 9 steps that help guide her through the process of brushing and flossing her teeth, because the implication being that without that, she would miss steps and struggle. And that really just doesn't match up with what we think about in our long COVID cases, particularly those who have really mild cases and don't require hospitalization and aren't sort of in the ICU. And I don't bring this up to indicate that such patients don't need care. They absolutely do, but it needs to be the right kind of care. And these messages have the potential for nocebo effects, where patients individuals are thinking that they're really at risk for suffering. And we're seeing these expectancies play out in the data. There was a longitudinal cohort study of 751 healthcare workers, and they found that after adjusting for baseline somatic symptoms, so what they already had, COVID symptom expectations and self-reported history of COVID predicted worsening somatic symptoms over a 21-month period, but lab-confirmed COVID did not, suggesting that somatic symptom burden may be more related to expectancies about what you might face if you had COVID than and sort of psychosocial effects of the pandemic rather than the illness itself. And then a series of studies published together in Health Psychology really teases this apart. And these are folks who over this longitudinal study remained COVID negative, which is something that's hard to do anymore because most people will have had it. But they demonstrated and replicated that specific beliefs about COVID and beliefs about oneself predict the experience of later unexplained symptoms. The strongest predictor was belief about the severity of symptoms that one would experience if they got COVID. And this is after controlling for their actual risk factors, their genuine risk factors for having a bad outcome, their baseline somatic symptoms, and their anxiety. And so what they found is that the relationship between how sick you thought you might be and your later symptoms, absent any COVID illness, was fully mediated by your own perception of your body's sort of ability to fight off disease, as well as their own perception of their resilience and their ability to cope effectively with stressors, right? Interestingly, when beliefs were included in models, anxiety was no longer a predictor of later development of somatic symptoms. It really seems to be working through, right, these specific types of core beliefs, suggesting that these are important areas for us to be addressing for interventions. I did touch on this study last time I presented. It was a study that really showed that anosmia was the only reported symptom that clearly differentiated those with a history of serologically confirmed COVID from those without or who self-reported COVID. It did not go over well. It was a really big firestorm in the patient sort of advocacy space. And there were arguments that the methodology was flawed because patients with long COVID might have lower antibody responses, and so you can't really tell if they ever had COVID. But at the same time, there were other studies that were done that sort of speak to this same issue, and I think in a telling way. They didn't get so much press because they were sort of pitched in a different fashion. These are data out of the Netherlands for the early in the pandemic. They followed 76,000 people, looking at serologically confirmed positive and negative COVID cases that were matched well, and they corrected for the prevalence and severity of symptoms before a COVID illness. And what they found is that of those who had COVID, 21% reported persistent symptoms, but over that same time point, about 9% of infected individuals did as well. And so that delta, 12.7%, is thought to be the proportion of individuals who will have long COVID that's really attributable to their infection itself. Right? Said another way, of those who have persistent symptoms, about 60% of people, it's thought that those symptoms are really due to the nature of their illness. But in a really sizable minority, 40%, it doesn't seem to be the case that COVID itself is likely the driving factors. They suggest that maybe targeting these dysfunctional beliefs and other issues might be useful in helping patients bounce back. So I'll bring it down to the level of patients who are showing up in long COVID clinics. These are data from 323 people who were seen in our long COVID clinic called the PACT. They were not necessarily coming in because they had cognitive concerns. But what we're seeing is, when you ask it just in a binary way or whether you make it a more stringent criteria, we're seeing much higher rates of subjective cognitive dysfunction relative to objective cognitive difficulties. We're also seeing higher rates of depression and anxiety. And for all of these issues, our younger patients tend to be more symptomatic than our older folks. And what we're finding is that after we account for important demographic variables and illness variables, like whether you needed to be in the ICU, it really seems to be depression symptoms that are causing or related to that split between subjective and objective cognitive functioning. And so these folks didn't necessarily have cognitive concerns that were bringing them in. They could have had primarily just pulmonary issues or any of a number of sort of long COVID symptoms. But Doug Whiteside and his group out at Minneapolis have done some really nice work using the PAI, which is that instrument that you saw in our patient presentation earlier, showing that our long COVID patients who do show up to neuropsychology clinics have elevated rates of somatic complaints that are more than 2 standard deviations above the mean, as well as relatively high rates of clinically significant depression. So not terribly surprising. They did find that these rates of psychiatric distress don't differ based on whether someone was hospitalized or not, so sort of this as a metric of the severity of the illness. So there have been hypotheses that the experience of depression or anxiety post-COVID might be a manifestation of the inflammatory response to the illness itself. It may be sort of a symptom derived from that, but the fact that we're not seeing sort of a correlation with how sick somebody got it tends to sort of suggest that other issues are at play. And around the neuropsychology water cooler, the talk has long been that these patients really present in a manner that seems very similar to what we see in post-concussive syndrome. Higher rates in women, nonspecific symptoms, this discrepancy between subjective and objective findings in terms of cognitive difficulties, symptoms that are lasting longer than you would expect given the nature of the illness or injury, and a close tie to psychiatric symptoms. And so in their second paper, they looked at 200 patients with long COVID and 100 with post-concussive syndrome and gave them all the PAI, and these are all clinically presenting individuals. None of the long COVID patients were hospitalized or in the ICU. These are all folks with relatively mild illness. And you just see a really, really consistent pattern across these two patient groups with very marked somatic preoccupation and depressive symptoms. So they're replicating their findings. They're doing that in a different phase of the pandemic when it's not, when the notion of getting COVID or having COVID isn't, it's less lethal. There were no lockdowns. People had vaccination access and things like that. And yet we're not seeing a shift in the psychiatric symptoms. So it's very clear that long COVID patients and PCS patients have similar psychological profiles, suggesting that they might be amenable to the same types of treatments. And so that's the last sort of area that I want to talk about and leave some time for questions. So the American Congress of Rehab Medicine have issued their guidelines for the treatment of long COVID, and they really do rely heavily on basic CBT principles like addressing stress and maladaptive coping styles, including symptom avoidance and fear avoidance, catastrophizing, and somatosensory amplification. There's also a real need to address expectancies and provide good psychoeducation. It is the case that the modal outcome for patients, even with long COVID, is improvement over time. There does tend to be a subset. It appears that still experiencing long COVID. We're not sure yet sort of what that particular patient group is, but I imagine that it will likely end up being folks who have more complex psychosocial contributors to their symptoms. And working with patients, it's really important to be focusing on functioning and not causality. This patient group is very sensitive to the notion that they're not going to be taken seriously, that they are going to be dismissed, and that we don't appreciate their suffering. And so establishing a good rapport and helping them focus on improving functioning, setting aside the issue of we don't have the tools to sort of determine whether your level of inflammation is the driving factor in your long COVID symptoms, but here's what we know is likely to help you, can be really important in getting patients on board with us. That said, we don't have a lot with respect to empirically supported treatments in long COVID. This is a study that came out earlier this year out of Amsterdam. It's a randomized clinical trial where patients were assigned to 17 weeks of cognitive behavioral therapy for the treatment of severe fatigue, which really pairs very closely with cognitive complaints in long COVID populations, compared to treatment as usual. And what they found is that at the end of treatment, the CBT group showed statistically significant improvements with an effect size of 0.69, which is pretty reasonable for this space. And those symptoms persisted over a 6-month follow-up, which is really encouraging. There were also improvements seen for subjective cognitive dysfunction, somatic symptoms, social functioning, and physical functioning, all of which are really in the direction we expect, which is, of course, promising. And then there have been 2 other CBT-focused trials, one using an 8-session group psychotherapy, targeting somatic symptoms and looking at outcomes right at the end of those 8 sessions. And you see the focus of those 8 interventions on the side of the screen. They're really nothing special, very sort of bread and butter CBT approaches. But they did find reduced subjective fatigue and improvements in coping strategies. And then more recently, Frisk and colleagues conducted a very concentrated sort of 3-day intensive of CBT, and looked at outcomes at 3 months, and they were finding beneficial effects for fatigue, as well as dyspnea and exercise capacity. People had reduced number of sick days and increased functioning. So that's a very good start. I think we need more outcomes if we're really going to bring patients on board with the idea that our interventions, particularly non-pharmacological interventions, can be helpful in this patient population. We want to know which patients they're most appropriate for and given when. And wrapping up, I was heartened to see this editorial or commentary in Lancet Respiratory Medicine earlier this year. The authors are pulmonologists who are really lamenting the fact that they're not seeing a close correlation between what patients are reporting in terms of their symptoms and the results of their workups, and that there's this discrepancy in what they're arguing for, and they're calling a new paradigm shift is to really look at broader contributors to symptom experience. Obviously, this is not a new paradigm for us. This is something that we work with all of the time, but I think it's nice to see that others are sort of appreciating the importance of mental health in patient illness experiences. And that's something that we've been doing here with the Long COVID Clinic since April of 2020. It's led by Ann Parker, who's a pulmonologist and critical care medicine physician. We have very close ties here with our department and with physical medicine and rehab psychologists. We meet every week in a multidisciplinary sort of treatment setting, and the mental health symptoms and cognitive symptoms are really take up most of the time in terms of what we discuss with our patients and helping them move forward. And I think it's hopefully useful to our patients. And so I'm going to stop there. I'll just give a little shout out to the PAC team because they're really a wonderful group of folks to work with.
Share the mic with you. Great talk, Dr. Vannorsdall. That was really interesting. Quite illuminating for me. It's maybe not surprising that depression would color an awful lot of the experience of these patients. And I guess when I think about other patients who are focused on somatic illness, I guess I've often been in this situation where sometimes the patient can be very fixated on the idea that no, it's not psychiatric or psychological, it is very much physical, and you, I think, very appropriately talked about emphasizing functioning and not causation. But I guess the tricky part sometimes is getting the patient to accept that they need that psychotherapy can help and/or psychiatric medication can help. And I guess I'm wondering, how often are you in the position where you really have to work hard to persuade them of that?
Fairly often. Although I do think that there's actually something that works in our favor when it comes to the long COVID patients, in that they appreciate that this is new and that science is ongoing and that we're not quite there yet. And I think for some of them, they hold out hope that eventually we will have sort of a biomarker that'll say, aha, that's why you are tired and sad and feel very foggy. But we sort of set that aside when we're successful and say, we're working on it, we're trying to get there. In the meantime, we have these interventions that we know can be helpful for patients who have very clear, you can see the tumor on their scan, you see that they've had a stroke or a brain injury, and we're able to help them function better and feel better in the context of having this health condition. And so that's what we want to do with you too. And so when we can get patients at least to that spot, I think that that's, a step in the right direction, if not a full win.
Mm-hmm, mm-hmm. Great. Other folks have questions? Dr. Bienvenu. Repeat the question. Has there been blowback from CBT, from advocacy groups about CBT trials?
Yes. There have been, right? People are getting very good, learning a lot about scientific methodology. And patient groups are talking about the limitations of open label trials and the lack of blinding and lots of different issues. It's very, very similar to the ME/CSF literature, the chronic fatigue literature more broadly, with respect to patients sort of arguing that the studies are fundamentally flawed and we're not hearing them.
Interesting. Thanks. Other folks? Yes, go ahead, Dr. Carnell.
Yeah, I think that, when, sure, so she's asking if there might be a subset of patients for which there is sort of an inflammatory process that's leading to both the psychiatric and the cognitive presentation of patients, and I think that's absolutely possible. I think it's sort of naive to think that when 78% of the population has been exposed to COVID, that we're not going to see those patients, around, 5 to 7% of individuals will have a somatic symptom disorder at some point in their lives, that they're not going to show up in the context of COVID. I think that they are. So I think that's one bin, but that doesn't exclude the possibility that there are others. And that's why I think it's really important for us to be doing looking at phenotypes and trying to be able to make sure that we're looking carefully at particular symptom clusters and exploring pathways in those groups, because a paper came out Friday, I think, in JAMA, showing that 13 inflammatory markers were not differentiating long COVID symptoms, but they were doing, they were taking everyone and not necessarily breaking it down by those who have maybe highest tier cognitive difficulties and psychiatric symptoms.
Dr. Nestat.
Yeah, I think so, and we saw our patient today. Yeah, so he was asking whether, he was commenting that some patients will get very fixated on there being Epstein-Barr or some other sort of marker that can be measured, and that's been sort of a phenomenon in the chronic fatigue literature, and whether that might be happening here and be related to sort of stigma. And I think so. Patients do, sometimes some patients feel very strongly that they want to find the thing, the measurable sort of aspect of what's floating around in their body and making them feel this way. And that can be a real challenge to sort of move off of that, because even when they're sort of in the room with you and they get it, they're circling back with emails about sort of mold exposure and other things that we don't have good data for.
Right. That sense that when you can see it and when you can measure it, it's real, and somehow if you can't measure it, it feels somehow unreal. Dr. Tice.
Yeah, thanks for the talk. And similar kind of question. So we talked a little bit about post-concussive syndrome having certain symptoms that resemble that in the post-COVID period. I'm curious if in the literature, if there's been a separating out of those who might have like post-influenza, post-West Nile, like do those symptom clusters, are they distinguished from one another? Like what does that look like?
Right, so you're asking whether we see different symptom presentations in people who've had other infectious illnesses. Certainly we know that infectious illnesses can be associated with, cognitive declines as well as psychiatric symptoms. I don't think I've seen anything that's really characterized well within the long COVID space, sort of, okay, you're a long COVID person who also had Epstein-Barr and you've had influenza, and are you presenting differently than somebody else who's had only one of those insults?
Thanks. Other folks? Yeah, go ahead. Dr. Levenberg.
Right. So I'll preface it by saying I'm a psychologist, so I'm not prescribing medications. There are a number of RCTs that are underway looking at different potential agents to help. SSRIs are one of them. We've looked a little bit with Paul Rosenberg at stimulant medications. There isn't anything that happens to have sort of come to the top of the pack in terms of efficacy. There are studies also looking at SSRIs to help minimize the acute symptoms of COVID, which I think is really interesting and might be, in theory related to reduced long COVID symptoms as well, but I think the data are still sort of playing out.
Well, I'll ask you on the medication front, you mentioned the issue of Paxlovid, and people who take Paxlovid are 25% less likely to develop long COVID. Is that a reason, would that be a reason that everybody who tests COVID positive should take Paxlovid?
I don't know the side effects and risks of Paxlovid, so it's probably outside of my wheelhouse to sort of weigh in on that. But you could imagine a time when we're able to sort of get a better sense of risk factors for developing long COVID. I think we've got some in mind that might suggest that particular patients, it might be of benefit for them to take that to help reduce the likelihood of long COVID, even in the presence of potential side effects.
Anybody else? Dr. Lipsey.
How useful do you think the term brain fog is for the cognitive problems that these patients have? It seems to me it's a new word for an old condition that's hard to describe anyway, and it's associated with a lot of psychiatric disorders, especially affective disorders. But it seems to me the use of the word brain fog kind of implies a certain etiology for the patients.
Mm-hmm. I absolutely agree, and I probably use the term brain fog myself, even though I hate it. Because what I'm really interested in is sort of walking through each cognitive domain and finding out how a patient's doing and what they're noticing and experiencing in the language that we use. Is it attention? Is it working memory? Are you having retrieval difficulties or word finding problems? Because that gives us a better sense of how we can help. It also tells us a bit more about where in the brain we think any sort of dysfunction, if it's present, is really happening. Fog is such a vague term. It's just sort of not useful. It's basically saying I feel not right.
Right. Right. Reminds me of the term that I think it's neurologists who sometimes in the emergency setting will use the term delta MS, change in mental status. That is about as vague as it gets. Something's happening, which isn't right. Anybody else? If not, we'll thank Dr. Vannorsdall for a really terrific grand rounds. Really appreciate it.